Hello, my name is Kuritzky. I'm a family medicine physician, current title Clinical Assistant Professor Emeritus, University of Florida, Gainesville, Florida. I had the good fortune to give a presentation at the Pain Care for Primary Care Clinicians meeting in July in Orlando, Florida. My charge for this particular session was comprehensive diagnosis and assessment of pain. And three things that I hope every participant in the audience left with are: number one, it's important to make as concrete a diagnosis as you can. The reason for that is that by just finding a specific diagnosis, the diagnosis itself, if attended to, may help to resolve the pain situation. For instance, to say that a patient has back pain, lots of treatments could be appropriate. But were you to have determined that that back pain came from an osteoporotic fracture, you would then know that a drug like calcitonin might be specifically helpful to that diagnosis. Number two and number three are really combined. They are to make a finite assessment of pain, a concrete metric, and a concrete metric of functional status. The reason for doing this is twofold. The first is you want to document the patient's status at baseline, and you want to set upon a plan for the future of what your goals are, recognizing that it would not be wise to promise a patient that you can totally abolish pain, but that you can rather make inroads into the pain, which will hopefully really improve his functional outcome. After all, even if we were to provide very successful pain reduction, if the patient's functional status didn't improve, we really wouldn't consider that a success. So, recommendations include to use a pain scale. And whether your pain scale is something as simple as a Likert scale, 0 to 10, which is called an 11-point Likert scale, or something more sophisticated, doesn't really make any difference. Just do something that you can document in the chart. Similarly, there are numerous functional status scales that talk about a patient's basic life activities, whether they can cook for themselves, toilet themselves, engage in recreational activities. Find out what the patient is not able to currently do due to their pain, and then find out what their goals would be. You can prove the value of your pain intervention by showing that the patient has been able to move towards their functional status goals. Thank you for participating. I hope that you've enjoyed this Journal of Family Practice 3 in 3 and can find these items useful for your own clinical setting.